All right, let's move on to chest tubes. All right.
Yes.
There's a lot that's changed about chest tubes in the last few years. We talk about chest tubes, you and me, probably more than any
All
other
the time.
procedure that we have to talk about.
Because we put a lot of chest tubes in.
We do.
Yeah,
we do.
a lot. Way more than we do thoracotomies or VATs.
Yeah. It's really all the time. So one of the interesting things that I read recently and I brought to your attention, I just didn't know about this, was irrigation after hemothorax. So it turns out that the Western Trauma Association recently published a paper endorsing the idea of doing thoracic irrigation with hemothorax. What is the reason? Why would we irrigate after a hemothorax? What are we preventing? What complication are we worried about?
Yep. Excellent question. So I think the primary reason why people, and us included to a certain extent, do thoracic irrigation is to get rid of any residual hemothorax, thereby hopefully preventing the need for any secondary intervention. So that's in general the reason why we do it. And I think it's important for emergency medicine, especially where they put the chest tube in and they manage up front the first part of that chest tube management, because it's something that ideally is done pretty soon after that chest tube goes in.
Yeah. So there's a paper in 2017 that describes pretty well how to do it. Since I've never done it, I read the paper. So basically you start with your chest tube that's in, you suck out the blood that comes out. Once it's sort of stopped coming, you irrigate the chest cavity through that same chest tube with warmed normal saline. The protocol that I read described putting 500 cc's in first, basically sucking that out, then putting in another 500 cc's for a total of 1 liter. And then that basically provides the irrigation that will hopefully reduce these secondary complications that you're referring to. And so now to see the Western Trauma Association kind of come out with a paper saying we recommend this, I think is really thought-provoking and maybe something that most of us will start doing. Doesn't sound like it would take very long. Doesn't sound like it's very hard to do. So should this be something that we think about doing? And if so, which patients? Now, the 2017 study, the indications, they actually objectively looked at it, but the indication for doing it was the trauma surgeon decided that they wanted to do it. And it was based on imaging, but it really didn't say what the criteria were. So what are the theoretic criteria for doing this?
Yeah. So I agree with everything that you said, and I have 3 comments. So the first is, yes, for technique, there really isn't a standardized, acceptable, or accepted technique. And I would say exactly what you said is probably the simplest way to think about it. Chest tube goes in, and to kind of get into the second question, who gets it? You get a repeat chest x-ray or a CT scan ideally, and you see that there is residual blood in the hemothorax that the chest tube is in. With sterile technique, you would pour in, and you can use a 2mm syringe. And I think that 2017 paper is a great one. We should pin it up for everyone to look at, because it kind of outlines, as a reminder, how to do it. But you're basically instilling 2 sets of 500 cc's of warm normal saline, letting it slosh around, much like we used to do streptokinase or TPA.
Yeah.
And then you suck it out using a yank hour. And you do that twice. And there is a device available on the market, at least one, that is commercially available that can help with that irrigation process. But really, there's no need for that, because we've done the simple 2mm syringe and normal saline method, and it actually works fairly well. Okay, second comment. I think you're right. This has all mostly been driven by that group in Milwaukee. Great group of trauma surgeons, and they've really pushed this forward. And there was a bunch of these single center sort of studies and a couple other smaller studies, but then the Western Trauma Association Multi-Institutional Trial Group got on board, which I think was great. They had about maybe 11 study sites, and it's interesting because they did not standardize anything. Yeah, including the technique that was used. They just didn't standardize anything. And I think in some ways it's bad for sure, but in some ways it allowed more people to enroll more patients to prove the concept. And so I think that part was good. And what that trial showed was that there was a modest decrease in the need for a secondary intervention. I think it's really important for the listeners to understand that when I think about secondary interventions, I think about the need for a thoracotomy or a VATS, like serious. You put the chest tube in, there's blood left over, and we need to do a VATS to clean the chest out. If you look closely at the study results, if you look at VATS and thoracotomy, the things that we really worry about, the reality is they're very similar, and they really did not affect a change in those interventional outcomes. But if you look at the need for a second chest tube, for example, which although it's not a big thing, it is not a super benign thing. And I'd prefer not to get a second chest tube if I can get away with just having one put in my chest. So I do think that although it was a modest decrease in the need for secondary intervention, and we're mostly talking about the need for a secondary chest tube, it was still worthwhile. And I think you said something that I think is really important. If you really think about it, it's a super easy thing to do. You can do it in the emergency department. You don't have to move them to the operating room. You don't have to move them to some monitored bed. You're basically pouring normal saline to the chest. It's very inexpensive. The cost is virtually nothing compared to even opening up a new chest tube or definitely going to surgery. So I think if you really look at what it takes to do this, technically, cost-wise, logistics-wise, and person power-wise, and the fact that it decreases the need for another chest tube, I think it's worthwhile. And so we have very slowly started doing it, and it's very easy to do. And at least anecdotally, I would agree with those study results. And I think it's a super simple thing to do. And it looks like once that chest tube is stopped putting out, if you put it in, there's red tinged fluid that comes back. So there's definitely red cells in that effluent. So I think it's worthwhile.
Okay.